36 state-of-art manufacturing facilities, 300 plus production portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FTFs in the world and is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Experience Sharing Program in Managing PPH, we have got Honorable Speaker Dr. Dipti Mishra with us. Welcome, Madam. Dr. Dipti Mishra is DNB from Mumbai, HN Hospital, Mumbai, MBBS from Gujarat, is proficient in all assisted reproductive techniques, including IUI, oocyte retrieval, embryo transfer, just to name a few. Is teaching of MBBS and MD students, has proficiency in patient counseling and training subordinates, owner at Sidar Gynec and Multispecialty Hospital, consultant gynecologist at Sambol Hospital, and Madam has attended several conferences and has done several presentations on various topics in gynecology. Over to you, madam. I'll run the
Thank you.
slides.
Thank you, Dr. Prashant. So we are discussing today the role of carbetocin in PPH. So we'll first overview about the PPH. What is PPH? Right. So though the childbirth is a joyous event, the labor is painful phase. Blood loss during delivery is common. However, if it is more than limit, it cause of concern. A considerable proportion of a woman experiences heavy blood loss after delivery, so much that some cases they are even very lethal. This condition is called PPH. Postpartum hemorrhage can be defined as a loss of blood around 1000 ml coinciding with signs and symptoms of hypovolemia within 24 hours of delivery of a fetus or intrapartum loss. This picture showing us illustrate the normal postpartum patient and the patient suffering from PPH. In normal situation, after the placenta deliver, the uterus contract and attains normal tone. However, improper contraction of uterus allows more blood loss during PPH, and postpartum hemorrhage is common even in the women with who are normal or not even all not at all risk. They are suffering from PPH, and it is a main important cause of maternal mortality in low economical countries. It is also primary cause of nearly quarter of all maternal deaths globally. Next. So now PPH, hemorrhage is an unfortunate event many women and their family experiences. It is a leading cause of maternal mortality, accounting about 35% of all maternal deaths. Developing countries have a high maternal mortality ratio that is almost 240 per 1 lakh live birth. And this ratio is very low in developed country, that is almost 16 in 1 lakh live births. Globally, every year, about 14 million women suffers from PPH, and this incidence of PPH reported around 2 to 4% after normal vaginal delivery and 6% after cesarean section. In developing country, the risk of developing PPH is so high that every 1 in 1,000 women has a risk of mortality. And it has been observed that most deaths from PPH occur in middle and lower economic countries. In India, around 38% of maternal deaths are reported to be due to PPH. Of the global maternal deaths, 25.7 of maternal death takes place in India, and that is almost two-thirds this attributes to PPH. India has unexpectedly high maternal deaths, that is almost 450 per 1 lakh live birth. Next. Yeah. So these are the etiology of postpartum hemorrhage. This could be there are 4 T's you can remember. The first is a tone. When the uterus is unable to contract after the delivery of a baby or a placenta, it leads to continuous bleeding causing PPH. Second is thrombin. If the patient is suffering from any disorder, blood disorder, that such as failure in clotting, PPH has a high chance. Third is trauma. It is an injury to the birth canal and rupture or a laceration or uterine inversion. This could lead to heavy bleeding. And fourth is a tissue. Tissue, ideally, all the placental tissue should be removed after delivery. If some tissue retain or there is a clots or abnormal placenta, it can lead to PPH. Next. Yeah. So these are the sign and symptoms, clinical symptoms. So in which the amount of the blood loss and the associated there is a drop on the hemodynamic status and the symptoms what patient suffers. So initial blood loss that is around 500 to 1000 ml. So around 10 to 15% of the body weight. That time there may not be any changes in the blood pressure or a pulse rate. Patient may feel palpitation or dizziness and tachycardia. While the mild loss is almost 1000 to 1500 ml, patient's blood pressure may be slightly low, around 80 to 100 mm of Hg, and patient may feel weakness, sweating, tachycardia. In moderate blood loss, it's almost 1500 to 2000 ml. There is marked fall in blood pressure. It's around 70 to 80 mm of Hg, and patient may feel restless, pallor, and oliguria. And severe case of PPH, almost 2000 to 3000 ml of blood loss, and patient may blood pressure may be profoundly fall around 50 to 70, and patient may collapse because of the air hunger and there is anuria. Next. Yeah. So now the diagnosis, we are reaching to the diagnosis of PPH. So diagnosis of PPH is challenging. However, timely diagnosis can save a life. Initial evaluation should involve rapid assessment of a patient's status. Tachycardia and hypotension generally are less apparent, but if they are observed, then patients should be treated immediately as they are alarming sign of PPH. It is important to monitor the vital signs and the blood loss continues for diagnosis. Any deviation of a vital sign should be taken seriously. At the time of hemorrhage, it is essential to examine the entire genital tract for the laceration, hematoma, and sign of uterine rupture. The manual examination for the retained placental tissue should be done. A bedside ultrasound can be used to check the uterus is not contracted. At the same time, the patient should be evaluated for the uterine inversion. Additionally, there is need for laboratory assessment which supports the diagnosis of PPH. It includes complete blood count, platelet count, and this hematocrit, coagulation studies, and sometimes the assessment of the fibrinogen. Next. Yeah. So this is the different causes of PPH and how we are approaching to that. So in depth, first cause was the tone, uterine tone. When there is a poor uterine tone, when we feel it on per abdomen, we can feel that uterus is flabby, relaxed, and we can investigation see coagulation profile, urea, electrolyte, right? And on sonography we may found that there is a rupture of uterus or there is any inversion. While management of the PPH in this atony of uterus, we can give the uterotonic drugs like the oxytocin, prostaglandins, and ergot alkaloids. And the second is if fail, it doesn't respond to the uterine uterotonic agent. In that case, we can go for the surgical management. The second cause is due to trauma. The second cause was trauma. So we are just checking the genital tract for any bleeding, any uterine rupture, or any extension of the cesarean scar. And then according to we can deal whether it is cesarean scar rupture, then we are just do the stitching and all, and then we can confirm on the sonography when it's a normal delivery, right? And repair of the genital tract, that is the treatment for the same. Sometimes we may need the pelvic arterial embolization in case of the broad ligament hematoma or the supralevator hematoma. The third is retained tissue, that is a placenta, retained placenta or the membranes. In that case, we have to do examination under anesthesia, and the same time we can go for the manual removal of manual removal of the placenta. Causes coagulopathy. So coagulopathy, we can diagnose that in spite of good uterine tone, there is continuous bleeding. So in that case, we can go for investigation like blood count, coagulation profile, and urea and electrolyte. And the same, the management can be medical or a surgical. Same, we can give the uterotonics and the blood component and the IV fluids. Next. Yeah. So now there is a rationale of development of carbetocin in new heat stable formulation. So oxytocin and ergot alkaloid, They should be kept in a refrigerator to avoid the degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should store between 2 to 8 degrees centigrade. The resource poor countries, they do not have cold chain transport and a storage capability. Heat stable carbetocin, on the other hand, it's stable at room temperature and has a long shelf life of 24 months at 30 degree and 75% humidity. This formulation can avoid need for cold chain storage and logistic, and it is provided in a vials. This is need for development of temperature stable carbetocin formulation, which can be convenient for use. Next. Yeah. So now these are the use of a uterotonics agent. We can use the administration, the timing of the administration, that is at the time of the crowning of the baby's head, that is in the normal delivery. Second, we can give at the time of the delivery of the anterior shoulder, at the time of second stage of labor, and following the delivery of placenta. The prophylactic use is used for the prevention of PPH and active management of the third stage. The therapeutic use is management of PPH. The different molecules are oxytocin, carbetocin, ergometrin, and symptometrin. That is find it's a fixed formulation of 500 microgram of ergometrin and 5 units of oxytocin and misoprostol. Next. So this is the how the oxytocin and carbetocin are different. So, carbetocin is a new uterotonic agent and was created by making several modifications to the oxytocin structure. Chemically, it is a synthetic long-acting analog of oxytocin, and it is indicated for the prevention of postpartum hemorrhage due to uterine atony. It is administered as a single injection of 100 microgram, and it is available in a vial of a 1 ml solution. Pharmacology of carbetocin. It is a prolonged half. It has a prolonged half life and it reduces the enzymatic degradation. Next. So now the carbetocin clinical evidence. So yeah. So difference between the oxytocin and the heat stable carbetocin. So in brief description, the oxytocin is a synthetic cyclical peptide from form of a naturally occurring posterior pituitary hormone and binds to the oxytocin receptor in a uterine myometrium, stimulating contraction of this uterine smooth muscle by increasing the sodium permeability of a uterine myofibrils. While carbetocin actor, it's a long-acting synthetic analog of oxytocin with agonist property. It binds to the oxytocin receptor in a uterine smooth muscle and resulting in a rhythmic contraction, increase frequency of existing contraction, and increasing uterine tone. Now, according to pharmacokinetics, oxytocin can be given IV and intramuscular almost immediate action with a peak after 30 minutes. And intramuscular dose, it's a slower onset of action, taking 3 to 7 minutes, but produces long lasting clinical effect up to 60 minutes, and the half life is 1 to 6 minutes. While carbetocin, when it is given intravenously, sustain uterine contraction within 2 minutes and lasting about 6 minutes, followed by rhythmic contraction for almost 60 minutes. While we give it intramuscularly, the sustained uterine contraction lasting for 11 minutes and rhythmic contraction for 120 minutes, and half-life is almost 40 minutes. Now the storage and the transport. So oxytocin, it's protected from the light. Storage is 2 to 8 degree continuously to preserve its activity. While carbetocin is a heat stable, the storage condition is up to 30 degree. Now, clinical indication, how they are different. So, for the induction of labor, we can use oxytocin, but we cannot use carbetocin. Same way, for the augmentation of labor, we can use oxytocin, but we cannot use carbetocin. For the prevention of PPH, yes, both can be used, oxytocin as well as the carbetocin. For the treatment of PPH, yes, both can be used. Next. Yeah. So they have the WHO has conducted champions trial. So in this trial, it is an international randomized double-blind active control non-inferior trial which compared the heat-stable carbetocin with the oxytocin for the prevention of postpartum hemorrhage during the third stage of labor in a woman giving birth vaginally. This is the largest trial in the prevention of PPH. This trial was conducted by a WHO Department of Reproductive Health and Research. In this trial, they included more than 30,000 women across 10 countries. Primarily, outcome of trial studied were proportion of women with the blood loss of at least 500 ml or a use of additional uterotonic agent and the proportion of women with the blood loss of at least 1000 ml. Next. Yeah. So in this study, they have compared, so they found that carbetocin was not inferior to oxytocin for prevention of blood loss, at least 500 or a use of additional utero drugs. When we compare the parameters, the blood loss was more than 500 ml. The efficacy of carbetocin was 15.5 and the oxytocin efficacy was 14.4. So it's almost same or in fact little more than the oxytocin. When we compare the blood loss more than 1000 ml, the carbetocin efficacy was 1.51 percentage, while the oxytocin was 1.45 percentage. Then, when, at least one anticipated AE, that is 4.9 in efficacy of carbetocin was 4.9%, while the oxytocin was 4.7. So, when we compare, so carbetocin was not inferior to oxytocin. Next. Yeah. So according to Cochrane based the carbetocin for prevention of PPH in this Cochrane database review from 11 studies involving 2,635 women were included. In this, the author concluded that for the women who are undergoing cesarean section, carbetocin resulted in statistically significant reduction in need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with the less bloodless compared to the symptometrin in prevention of PPH for the women who have vaginal deliveries and associated with the significant fewer adverse effect. Next. Yeah, so the guidelines for the recommendation. So in various guidelines globally recommended carbetocin, the table enlists the various guidelines and their recommendation on the use of carbetocin. According to WHO in 2018, only one of the following, that oxytocin, carbetocin, misoprostol, ergometrin, methyl ergometrin, and oxytocin and ergometrin fixed dose combination. These are the guidelines for PPH prophylaxis. And in Canada, SOGC guidelines, according to that, they are using carbetocin 100 microgram IV bolus. In New Zealand, the active management of third stage of labor prophylaxis uterotonics. FIGO, according to FIGO, carbetocin is one of the recommendation for the PPH management. In Germany, Australia, Swiss body, according to them, the carbetocin 100 microgram slowly IV and FCOG France guideline, carbetocin on proving non-inferior to oxytocin. Next. So now I'm sharing my case experiences. So first is Dr. Prashan, can I go ahead?
Yes, yes, yes.
Yeah. So my first case was it's a 28-year female. It's a primary patient, primary gravida patient, and 40 weeks of pregnancy. She presented with the labor pains and she underwent spontaneous vaginal delivery. After the delivery, we have given her prophylactic carbetocin once the delivery of the baby, means placenta occurs. And there was very means we experienced that there was extremely less blood loss, and we did not require any other prophylaxis like misoprostol or any ergotalkaloids. Right. So I think carbetocin X means I would like to directly use carbetocin if there is no cost, this thing concerns with the patient. So yeah, so now I move to the second case. In that we are using carbetocin in case of cesarean section. So I have a patient of 32-year female. She is a third gravida, previous one cesarean section and one abortion. And she came with the breech presentation. And this time she was planned cesarean section, and we have planned for the spinal anesthesia. So for that also we use prophylactically carbetocin. I didn't go for any ergotercloids or misoprostol or prostaglandin, and directly use carbetocin, and definitely we found that there was very little blood loss, and we did not require any other uterotonics, and patient was completely fine vitally, and definitely when we use carbetocin, so there are hardly any changes in hemodynamics as well. Now I move to the third case. So use of carbetocin in case of high risk pregnancy. Yeah. So in that case, I have one patient. Recently, I did cesarean section last week only. So she was 32-year female, and with she's third gravida with previous to abortion. Now she conceived with the IVF, and it was a twin pregnancy, diamniotic dichorionic, and she was 36 weeks. Previously, she had a myomectomy fibroid surgery, it's a scar uterus. She's a gestational diabetes, and she was posted for the cesarean section. So here we are expecting that she has a multiple factor like previous scarred uterus, like because of the myomectomy, and she is a gestational diabetic patient. Plus, she is a twin pregnancy because of the over distension. There is atony of the uterus. Uterus fails to contract. So we prophylactically we plan that there is a chances of this thing PPH because it's a high risk for PPH. So prophylactically we gave immediately at the time of delivery of the placenta we give carbetocin, and we did not we didn't find any PPH or anything, and it's controlled the single dose. So we were very happy.
Thanks for your cases. What about to ask you, generally you prefer intravenous route or intramuscular?
We generally prefer intravenous, but
Venous.
that depends for what reason. But even in the normal
Okay.
delivery also we use intravenous only. But you can use it intramuscular also.
Muscular.
There are difference of action. When we use it intravenous, then it is faster action and little means
Less.
duration
The
is
duration
little
is less.
slower.
Yes,
Yeah,
yes, yes.
lesser. But when we want to, it is preferred in cesarean section. But why, when
Correct.
we use it for the normal, so it's preferred that you give intramuscular. So action is little slower
Longer.
and
Yes,
it
yes.
remains
Longer.
for longer time, so it's better for the vaginal
Correct.
delivery. Yeah.
Some questions, madam. You
Yeah.
actually speaking for the doctor's benefit. What is the benefit of using carbetocin as first line drug to prevent PPH?
See, I think already mentioned that
Yes.
the first thing is it is immediate action when we use it
Yes.
IV bolus,
Yes.
and definitely very little blood loss. Even you don't realize that patient is with, even in spite of high risk, you're getting blood. So whenever I have used or whenever assume that this is high risk for PPH and we are using it, so we are finding very good result, and we don't need any additional thing. We don't even
That's
need
wonderful.
uterine massaging, and recently when I'm using in very means commonly when there is no cost constraint. So it is
Yeah,
really
yeah, yeah.
we should use as a first line drug.
Exactly. And in
Yeah.
almost all deliveries we use I mean prophylaxis for PPH, you know.
Not
So
always
almost all delivery.
when there are low risk or if we don't need
Yes.
things, there are no other things.
It
So we
is.
are using oxytocin, but sometimes it is not contracted. Then we need second, third dose of oxytocin. Then we need
Correct,
to give
correct, correct.
ethergine, ergotalcol, then sometimes misoprostol also, then prostodin. So there are so many things we are giving.
Yeah,
And
correct,
if they are
correct.
not working, then we go for carbetocin. But now onwards, since we know about carbetocin, we are straight away,
Correct.
okay, if there is high risk, give carbetocin.
Straight,
We are not
correct.
waiting for anything. Yeah.
And the condition is potentially life-threatening. So it's better that we
Yeah,
give a
yeah,
drug in the
definitely.
fastest
We
and
have
in the
to act
best way.
fast. We can't wait and
Absolutely,
say, no,
absolutely.
just
Yes,
give
yes.
and then wait for 5 minutes.
No,
And
no,
then
no,
if it
no,
is
no.
not acting, and then we'll give
Every
second dose
every
or
second
something.
matters. Minute is
Yeah,
लंबी
yeah,
बात है. Yeah,
definitely. It's
correct,
very,
correct, correct.
because recently I operated whenever it is high risk or I am suspecting that there is little more
Yeah,
bleeding. So even before delivering of placenta or after delivery, if it is high, straight away give carbetocin, then
absolutely,
see
absolutely.
any other thing we are giving or
Yes,
not. Yeah,
I mean it gives you a sort of a confidence, and then you can relax and concentrate on the procedure. I mean, a lot of
yeah,
advantages. Yes.
yeah.
And any patient profile specific where doctors can anticipate a PPH?
Yeah, there are many high risk patients. That means
Like
if
the one you said,
patient,
twins. Twins you
hello.
said. Yeah, like the one you said, twins.
Yeah.
Yeah,
So when we are see like previous twins, this means twins pregnancy where there is a over distension of
correct,
this
correct.
abdomen. So in that case, uterus this thing atony is possible. There is previous cesarean section, or there are previous history of PPH in that patient, or then any other high risk of PIH or something like that. In where we are expecting there any blood disorder, any past history of any coagulation disorder or any low
Okay.
platelet or any health syndrome. So in that case, we are suspecting that patient may go for means may land up with the PPH. So prophylactically, we can anticipate like this.
In our country, anemia could be a major cause.
Yeah, yeah,
Yeah,
definitely.
yeah.
Anemia is a major cause for that.
Any experience in case use of carbetocin in retained placenta?
I have not used, but I have went through few studies. So
Okay.
definitely, it gives a good contraction of uterus, and that retent tissue can come out with that. So
Yes, yes.
it produces the contraction. Because of that, the
Sustained
retained
contraction.
placenta can come out. So
That's correct.
definitely, it gives.
This would be a major advantage, I suppose, in RH negative mothers, especially in the periphery and in the interiors.
Yeah,
Yeah. Any
yeah, we
experience?
can.
Yes.
I have, I have used, but yeah, but we can use. There is no
Correct, correct,
contraindication,
correct.
nothing to related to because both the action of this mechanism of action is different than the RH this thing in
Absolutely.
computer. Yeah,
Anyway,
so we
we
can
give that
easily.
anti-D, etc.
Yeah, yeah.
Doctors generally use oxytocin for labor induction. In such
Hmm.
scenario, can a doctor use carbetocin for prevention?
Yes, yes, of course we can use it.
Yeah. And I suppose that's a place where many people will be using. In which case, I mean, you said you have answered already this question. I don't know. How well is carbetocin tolerated in your experience?
It is very well tolerated. Means none of the patient had any complaint or any change in the hemodynamic status. So
Very good.
I don't think so. Yeah.
I mean, PPH is a condition which itself is trouble, and the drug giving side effects is further trouble. I mean,
Yeah, yeah, but I think there are no major side effect for the
very good,
carbetocin.
very good, very good.
Little nausea, dizziness, or something like
That
that.
is, yeah. If patient does not respond adequately with carbetocin, what other uterotonics you would use in your order of preference? Huh? It should not happen. It should not happen.
I think carbetocin is the best thing, so I
Thank
don't think so.
God.
If it is not acting, then other might act.
First of all, I'll tell you PPH is a good topic to discuss, but no one should get a case of PPH is our honest wish.
So if they're using carbetocin, then I think we'll not get any case of
Good, good, good. God
PPS.
bless. Advantage of carbetocin or other uterotonics.
I think that we have already discussed, but
Yes,
still it is
single dose
it,
and especially doesn't require that storage
yes,
condition.
yes,
No? That's
yeah,
in
yeah.
our
So
country.
in
Yeah,
developing country or low
it's correct, correct,
economical
correct.
area, so we can easily use it without
Yes,
any
without.
cold chain transport.
Should it be kept as a reserve drug? I mean, you already said this. You are using it as a first line, but
Yes,
generally for the
yes.
people, yeah,
Yeah, when there is patient is poor, then we are thinking, but still we think that it is still cost effective. If you are using
correct,
so
correct,
many
correct.
other drugs, so it's
Yes,
better to use directly this thing,
finally,
carbon.
yes.
Yeah.
And final take home message for our audience.
Yeah. So I think carbetocin is very good drug, and as we already discussed that it is a heat stable, long lasting shelf life. It can be stored at 30 degrees centigrade at room temperature and 75% of humidity. Right. So and it is it controls blood, it controls PPH, and there is very less blood loss. Right. So it is a very good drug to use to prevent PPH. And definitely in the developing country like India, there are higher cases of means large number of cases of
Correct.
anemia and large number of PPH. And as we already discussed, that the India is the capital of a PPH and maternal
Yes, yes,
mortality is
yes, yes,
very
yes.
high.
Correct.
So definitely this drug we should use means very means commonly means you should not keep it as a reserve drug. You should use it promptly whenever it is required. When are anticipating any high risk for PPS, then definitely you should use carbetocin. It's a very good drug.
Thanks, madam. Thank you so much.
Yeah,
Thanks for taking
welcome.
time and addressing our webinar. And thanks all the doctors who took time from their afternoon busy schedule and came to attend this. Thank you, marketing sales team of Hitro for coordinating this. Thank you, Sai Srikar, for your IT support. Thank you so much,
Thank you.
madam. Madam, you can log out.
Yeah.
Thank you.
Thank you.
Wish you a
Thank
good
you.
evening.
Yes.
Yeah, good afternoon and good evening. Thank you.
Yeah. Thank you, sir. Thank you.
Thank you, madam. Thank you for joining, ma'am. Thank you so much.
Yeah. Okay.
Thank you, Sai, Shrikar. Thank you so much. Bye bye.
Bye, sir. Thank you.